Hi, good morning. Dr. Lee. Today I want to talk about high ankle sprain, which can be called as a syndesmotic ankle sprain. So, what it means is that it's injury affecting the distal tibial fibular syndesmosis, which consists of few ligaments such as interosseous ligament, the anterior inferior tibial fibular ligament or AITFL, the posterior inferior tibial fibular ligament or PITFL, or some we add transverse tibial fibular ligament lah. So this injury usually is 6% of all kind of ankle sprain without fracture lah, but it can went up to 20% in certain sports such as American football and hockey. So how does it happen? Usually it's caused by an external rotation at the joint, either together with or without dorsiflexion lah. So patient will usually give history of such mechanism of injury, and then they will complain of pain around the ankle joint, which is usually slightly higher than usual ankle sprain lah. The more common one is a lateral ankle sprain. So there will be some swelling, but it will be less than the lateral ankle sprain. So, but the most prominent symptom is the inability to bear weight lah, compared to other kind of ankle sprain. So usually it commonly misdiagnosed or underdiagnosed lah. So we might present with a chronic kind of a sprain. Each patient will complain of a chronic pain, prolonged recovery, and recurrent sprain. So when we examine this patient, so we can notice tenderness around the syndesmosis joint lah, which is the most sensitive sign we can see. Then we can still have some few specific tests lah. Then we can do is the syndesmosis squeeze test. This is the quite specific test lah. So we can when we squeeze the leg from proximal to distal, we try to elicit the pain in the syndesmosis joint lah. So some other tests such as Kliger test, we ask patient to sit in hip and knee into 90 degree. Then we try to reproduce the injury mechanism by external rotation and in a dorsiflex ankle. So also Cotton test, fibular translation test, where we try to translate the fibula. We hold the tibia. We try to translate the fibula whether can produce a pain or not, anteriorly and posteriorly lah. So this injury can be like other ligament injury, can be graded into 3 grades. First is just a ligament stretching. Grade 2 is a partial tear. Grade 3 is complete tear lah. But what is that? Then we proceed with the imaging when we can do to diagnose or to assess this kind of injury. First, most commonly is X-ray lah, plain X-ray. But most important thing, first thing we want to see is to rule out fracture lah, which is commonly happen together with this kind of injury, such as a Weber fracture lah. So other modality like CT, we might proceed CT when there is highly suspicious, but there is normal X-ray. So MRI will be the gold standard to assess the ligament injury lah. Then finally we come to this this presentation. We might have need to rule other differential such as fracture lah, like I mentioned, other kind of ankle sprain, and then also possibility arthritis such as infection, arthritis, or inflammatory kind of arthritis like such as gout. So next, how we're going to manage this? There's a certain criteria. There's your or clear indication that will proceed with surgery, such as instability, severe diastasis, or means a separation of the distal fibular joint, and increase what is that? The high grade grade 3 lah. So other than surgery, mostly patient will sufficient with just a conservative management alone. So what we can do is, in acute setting, we want to control the pain and swelling. We want to preserve the as much passive RM, pain-free RM as much as possible, and then to protect the surrounding structure lah. So we will ask patient to no weight bearing for a short period of time, and then might give analgesic, and then we are going to ask patient to do some RM exercise, and then also such as also do ankle pump to reduce the swelling. So after the pain and swelling subsided, then we might proceed with some strengthening exercises such as ankle isotonic, isometric exercise, increase do passive stretching such as towel stretching, and then also start the double limb balance activity or progress session at the exercises. So subsequently, then we can progress with more difficult progress session exercises such as single limb balance, increase strengthening exercise with resistance band, ankle exercises. So eventually the last stage, when patient might want to progress return to sport, we might need to add on start patient on walk to run, to jog, to run progression, and then start single leg weight bearing, single leg balancing, and then some plyometrics like jumping exercises. So we need to add on more sport specific drill as well to fully rehab. So this is my sharing for today. So thank you for listening.